So my disclosures. And I think these covers of these magazines, they show how our hearts and minds felt about HIV over the years, over about 3 decades, from awe to despair to a sense of victory, or at least a sense of achievement. And as Ken showed before, it's a doubtful achievement. I mean, obviously we did a lot, but if you look carefully at these data presented by UNAIDS and WHO recently, since 2010, in the last 8 years, we have the number of people living with HIV went up 20%. So it is, we achieved a lot, but still a long ways to go to actually can say that we conquered HIV/AIDS. And only in the last year, about 2 million people got infected. About 1 million people died of HIV/AIDS. So there's a lot to do still. And if you think in the region, in the Americas, in our region, in the last 10 years, the number of new diagnoses has remained stable for over the last 10 years, only less 1%. And that's an average. When you talk about average, always know that averages are misleading, which means that in some parts it went down and some parts went up. And if you look at least my country, in Brazil, in those age, MSM age up to 25 years of age, you end up 70% of 70 over the last 4 years. In Chile, it's going up. I don't know exactly here how it's happening, but it's going up in many parts. So there's a long way to go. And when you look at around the world, 54% of the new infections come from so-called key population, their sexual partners. But again, that's misleading. When we look at certain parts of the world, that represents almost all infections, 99%. So we have to look at each part of the world to look what we need to do. But the key message is that we still have a long way to go, and sexually transmitted infections are the main route of infection. But we have tools now to prevent it. We have tools that depend on antiretrovirals, tools that depend on behavioral change. But the first proof that antiretrovirals can reduce infection appeared in 1994 with the ACTG 076 that showed that it can reduce mother-to-child transmission. And if you look at remember that trial, they used AZT during pregnancy, during labor, and to the infant. So it included one arm, the last one, that one part of the intervention, the last one, was in fact was a post-exposure prophylaxis, was the baby who had already been exposed, which was not a new concept, because since there's a typo there, it's 1889, when Louis Pasteur treated a person who had been exposed to rabies, to a rabid dog, with a serum. And since that's been shown, and it works, there's never, ever been a failure of rabies prophylaxis if used correctly. All failures happened when the protocol was not followed, so it works. In HIV, for the first time it was shown that it could work. This case control study conducted by the CDC, by a Brazilian who worked at the CDC, still works there, Denise Cardo, she showed that in post-exposure prophylaxis with AZT could reduce amongst healthcare workers that had a needle stick injury, could reduce infection by about 80%. So soon after, so why does it work? If you look at it, when HIV is in contact with the mucosa, it enters the dendritic cells and goes to the regional nodes. So that's only when it gets to the regional node and starts really multiplying there, replicating there, that the infection is really established. But that takes about 72 hours when it's being carried there. So within this period of 48, 72 hours, we still have a window of opportunity to prevent the infection from being established. And if you look at the exposure route of transmission, the likelihood of an exposure becoming an established infection in sexual acts, per sexual act, is in the ballpark the same as a percutaneous needle stick injury. So if it works for one, it should work for the other. Because of that, after Denise published her paper, myself and a colleague called Lee Harrison from then at Hopkins, we proposed to NIH a case control study, prospective study, double-blind placebo-controlled study to look at PrEP. But the reason the reviewers did not accept our study was they said, as Ken mentioned, that it could lead to disinhibition, could alter behavior. So we're forced to do a small study to look at behavior impact. If having access to PrEP, that was 1998 we're talking, having access to PrEP would lead to disinhibition. So in that study, people had a 4-day supply of AZT3DC, which was the standard of care, was the best drugs available at the time, and they were instructed to start PrEP immediately if they had exposures that fulfill certain criteria, to come to our center, and if it's deemed that the exposure was a real exposure, they would receive another 20 pills for another 24 days, complete 28. If not, just replenish the pack, and they would come every 6 months. So first thing we showed that, if anything, behavior got better, so to speak. The ready availability of PrEP did not make they behave, have riskier behaviors. And infections, that was not designed to look at efficacy, but we look at infections. There were 11 infections for an incidence rate of 2.9. but in the group that ever used PrEP, 66 of them, there's only 1 infection. Of those 131 that never used PrEP, there are 10 infections. It's a hint that might work. And of that one who got infected was a person who had a M84V mutation on day 28. We never know if that person was selection of a resistant virus, or if he was already, or he was infected with the resistant virus. So one of the conclusions of the study was the underestimating his behavior with a study partner was the main reported reasons for not starting PrEP. And that was one of the reasons used for the IPREX study. Both Ken and I were authors of that paper, and if you look at the paper, the reasons for IPREX, that was one of the main reasons, that people did not recognize they were at risk. And then, that's when I first met Ken, I think was in 2000, because this paper, in fact, before it became a paper, it was first presented in 2001 at the first IS conference in Buenos Aires, which Pedro presided, and I think we first met Ken, I think 2002, when there's a meeting at the CDC to discuss PrEP, which eventually from that meeting they evolved to become the first guidelines for PrEP, and PrEP that was called post-sexual exposures, that was published in 2005. And as this is Ken in 2015, 10 years later, saying that, I mean, there's no, given that animal data, this case control study and my observational study, it would be unethical to conduct a study. So guidelines for PrEP and PrEP would remain based on case series, which they are. So the guidelines, 2005 were updated in 2016, and the WHO published their new guidelines in December 2018. And these are from the CDC. They acknowledge there are no proper randomized trials. But what they say, PrEP is recommended when there's a substantial risk of an exposure, when the source is known to be HIV positive. And, but in a case-by-case, is recommended in a case-by-case determination if a situation, if the source is unknown but would be HIV positive. On the other hand, it's not recommended when there is no substantial risk, or importantly, even if there are substantial risk, but it's over more than 72 hours later, because of what I showed in the beginning, because after 72 hours, the infection is established. If it has occurred, we have to wait and see. If it has occurred, it's treatment, not prevention that one needs to do. One thing is that anyone who's a candidate for PrEP should be tested, preferably with a rapid test contains antigen antibody. If it's not available, we should start a PrEP and then think what to do. Importantly, if one is at risk for HIV, is at risk of several other things, including, and most people forget that, pregnancy. So these things have to be thought of. And the guidelines now, they recommend, and that's both WHO and CDC, and at least in Brazil, we should use dolutegravir. It's tenofovir, lamivudine, or FTC, depending where you are, and dolutegravir is a third drug. If dolutegravir is not available, then do whatever you can. It can be atazanavir, darunavir, lopinavir, or raltegravir. But ideally, dolutegravir should be the third drug. Importantly, one should use it, should be 28 days, which normal or regular individuals normally can do it. We healthcare workers, when we happen to be needless to stick injuries, most of us don't do it for 28 days. Importantly, one of the deterrents of PrEP has been the need to do lab tests. This was presented at CROI this year from New York, about 575 patients who did receive PrEP with tenofovir, entrectinib, and dolutegravir, which what they show, it's probably difficult to read, is that there are no side effects, lab side effects. No one had liver or renal problems. So the lesson is just do PrEP, don't waste your time or your money doing creatinine levels or liver function tests, unless the person has something or shows any signs or symptoms of something. Otherwise, it's just a waste of time and of money. Just do PrEP and the person will be okay. But one thing, if you look at these data from the US, about persons who have insurance, in the US, in 2015, only 15,000 prescriptions for PrEP. So PrEP is not used at all. If you think the whole of the US, only 15,000 prescriptions of PrEP. If 40,000 people got infected, so the number of, if sexual transmission is very inefficient, how many people actually probably needed PrEP? And one of the reasons, this is a slide that Ken gave me a long while ago, and I think this from when he worked at Brown University before he moved definitely to Harvard. And in a place where people were, I think this is from 2010, long ago, but even though, in a place where people knew what they were doing, Brown University, where Ken worked, so they're aware of things. So if you look at it, of 3,600 exposures, PrEP, in people who actually needed PrEP, these are indicated, people had indications for PrEP, including sexual assault, pediatric sexual assault. Only 27% of the time, people offered PrEP. And only 46% of the time, people accepted PrEP. So no wonder it's not being used, because we healthcare workers are not offering PrEP. As I said, we're doing well, but not that well, because the number of infections went up, or the number of people with HIV went up 20% the last 80 years. But we have means to do things. And one of the things that we thought we could do was control the epidemic with treatment, mass treatment. And as Pedro showed this morning, mass treatment or treatment does things, but it cannot control the epidemic. We need to use the other tools we have. And that's something that Steph Barral published in Lancet, showing that there is a disconnect. At the individual level, it's absolutely wonderful. It saves lives. It's mandatory. But at the population level, we need many, many other things. Because we need to remember that treatment is treatment, prevention is prevention. We need to use all the preventative measures that we have if we want to control the epidemic. And I think we knew that long before these trials that were published in the New England Journal of Medicine during IS. These are data from the UK, in which this goes from 2004 to 2013. UK had reached the 1990 goals, but the mid-2000 and something, 2007, 2008. And these in blue are the MSM who acquired HIV while in the UK. And the number of infections went steadily up. Despite 1990, the number of infections were going up and up and up of people living in the UK. But if you look here in England, from 2013 to 2015, if you look all MSM in that brownish color, or of high-risk MSM in green, to 2015, 2017, the number of new infections went down dramatically. And that for one reason, PrEP. That was the only thing that changed. PrEP became available. And one thing, as was mentioned just now, one of the main important things from the recommendation when you start PrEP with someone is that if someone uses PrEP, that person needs PrEP. And PrEP is the best tool we ever had to control the epidemic. So in conclusion, the epidemic is far from being under control. And a combination of biomedical and behavioral intervention will be necessary to control the epidemic. PrEP is effective, safe, and extremely, reinforced, extremely underutilized. And as I think was said before, exactly, probably is exactly the same sentence, PrEP can be the gateway to PrEP, the most effective preventive biomedical intervention presently available. I cannot stress that enough. PrEP is the best thing we ever had, and we need to use it. So I want to thank the people whom I stole or gave me slides, and thank you very much.